Good evening, everyone. Today's module is actually module 6, and we will be dealing with the ear, nose, and throat disorders. And this is going to be a 1.5 hour class. And during our class, the topics of discussion will be diseases of the ear canal, then middle ear diseases, diseases of the inner ear. Then we will discuss regarding diseases of the sinusitis, especially the acute rhinosinusitis. We will discuss the common nasal trauma that as physician we are called to attend, and the foreign body in the nose, which as a physician will be called to attend in emergency department. Though the ENT people are involved more with foreign bodies and nasal trauma, you may be called in to manage these cases initially. And diseases of the paranasal sinuses, diseases of the oral cavity, and finally the common ulcerative conditions of the oral cavity, which will commonly present to you as a physician when you are practicing in your OPD. So this is going to be our agenda. Hopefully we'll be able to finish all this in the coming 1.5 hours. Again, otitis media, I'm going to discuss in a very detailed form because as physician, you have to be thorough with otitis media. Otitis media is defined as an infection of the middle ear space, and it is a spectrum of diseases that includes acute otitis media, chronic suppurative otitis media, and otitis media with effusion. So this is a normal eardrum, very reflective, and it has a cone light. If you project the light, there is something known as a cone of light. In acute otitis media, there is loss of the cone of light. Because of the acute inflammatory process, the eardrum appears angry. It is very red and it is very inflamed, and there is loss of the cone of light. Then in chronic suppurative otitis media, as I mentioned, the infection is more chronic. The eardrum becomes thin and decent, and finally a perforation happens in the eardrum. And through the perforation, there is a discharge. There is a mucopurulent discharge to the external ear. Then you have to think of chronic suppurative otitis media. The problem with chronic suppurative otitis media is that as chronic suppurative otitis media progresses, there is proliferation of the lining of the middle ear, forming cholesteatoma that leads to permanent middle ear damage and permanent hearing loss. And there is something known as the otitis media with effusion, where you don't have much of a fever, much of pain, etc. Just a feeling of fullness and decrease in hearing loss, most commonly seen in young children after viral infections. Common ulcerative conditions that use cavity. It could be minor ulcer where the diameter of the ulcer will be less than 1 centimeter, or major ulcer if it is more than 1 centimeter. The herpetic ulcer are typically multiple small 1 to 3 millimeter ulcers. Okay, so that is the difference between herpetic ulcer, minor oral ulcer, and the major oral ulcer. And again, depending on their duration, they are divided into acute, where they usually last less than 2 weeks, chronic, where they last more than 2 weeks, or recurrent, where they can happen in multiple episodes. So the most common acute oral ulcer is the aphthous ulcer, very common in our clinical practice. It was described as early as Hippocrates, and no specific etiology has been found. Usually they present with a clinically oval shaped with erythematous periphery. There can be several precipitating things like trauma, chemotherapy, herpetic gingivostomatitis, change in immunity. Everything can contribute to aphthy. Treatment is mostly supportive. You supplement with multivitamin, zinc, and topical steroid and antiseptic creams are more than enough to treat aphthy. Traumatic ulcerations can happen. Chemotherapy can also induce oral ulcer. Then the most common clinical thing that you have to be aware is the primary herpetic gingivostomatitis, which is caused by the herpes simplex virus. This is the classic presentation of the herpes simplex gingivitis or HSV1 infection. The treatment is again acyclovir and topical acyclovir, but the problem with herpetic lesions is that they can happen again and again, and many of them are associated with genital ulcers also. Then herpes zoster infection, as you are aware, the varicella zoster infection that remains in the nerve. Once you develop immunosuppression, they start to appear as painful vesicles. If they happen in the cranial nerve, most commonly in the trigeminal nerve, there can be herpes zoster ophthalmicus. The herpes zoster ophthalmicus can cause vesicular eruptions in the nose because of the involvement of the first division of the trigeminal nerve, commonly referred to as the HSN sign. The typical herpes zoster ophthalmicus, but usually it affects the nasal part because of the involvement of the first division of the trigeminal nerve. Again, there is something known as the hand, foot, mouth disease that is also very common in medical practice, caused by the Coxsackie virus infection in children. It is also a self-limiting disease. It will present with a painful vesiculo-ulcerative lesions involving the mouth, soles, and hands. There is no specific management, only pain relief and fever control is enough. Within 2 weeks, they will subside spontaneously. Then erythema multiforme can happen after virus infection and some drugs. And the chronic ulcer, one thing you have to be aware is the lichen planus. Okay, the chronic oral ulcer usually seen in lichen planus. The classic feature of lichen planus is the typical white lacy lesions in the oral mucosa, commonly referred to as the Wickham stripe. Okay, that aspect you have to be aware. Lichen planus, a very common cause for recurrent oral ulcer, and if you are seeing a white lacy structure in the oral mucosa, think of lichen planus. There, you will need the help of the ENT consultant or the dermatologist to take a mucosal biopsy, and through mucosal biopsy also you can make a diagnosis of lichen planus. And the treatment is corticosteroids and topical immunosuppressants. Right. So thank you.